All right. Hi, everyone. It's Connor. I am doing a video to try to get some education out regarding tube feedings. We are accepting more residents with a higher level of acuity. Unfortunately, that is the post-COVID market. We take what we can get because there's just not a whole lot of people to sift through right now. So if people come in on a tube feeding or pressure sores or lots of medications, we just kind of have to be prepared for that. So a tube feeding, we're going to see most people with a G tube come through our doors. Some may come with a J tube. Very few, if any, are going to come with an NG tube or an NJ tube. If someone does come with an NG tube, that is fine, but we're supposed to have a plan for removal. It's not supposed to be a long-term thing for us. Most of the people here that have a PEG tube use it because they can't eat or drink because of a stroke, or they can't control their secretions, or they're losing weight. Somehow they're failing and we need to make up the nutrition. Maybe they just don't eat enough. That's fine. We can manage that with the tube feeding. Please note, it's very important to use the correct feeding. If you use the wrong feeding, it could cause raging diarrhea, vomiting, just general feeling of not feeling well. People that are started on tube feedings generally start with a very low amount and they work their way up. Otherwise, they could develop refeeding syndrome. So you have to just kind of work to that level. I do just want to start with medications, though, being that is a big part of what we do. Medications should no longer be placed into one cup and mixed up, okay? We used to do that. The medications start to bubble, they turn into all cool colors of the rainbow, but unfortunately there are very few studies out there that really show that that's safe or effective for the medications. We should be placing medications into the body one at a time, and if they're going through a PEG tube, they have to be crushed and there needs to be water in between. So in this case, I'm just saying that resident A has 3 meds that need to be given. So you would want a cup, another cup, and the 3 small cups for the meds that you are giving. Fill both of the big cups up. You're going to need the water. Before you actually give the med, you're going to want to check the placement of the tube feeding. Now, the only true way to know a tube feeding placement is through x-ray, and that's something that is usually done when the tube is first placed. But when we do our routine replacements, which are about every 5 to 6 months, we don't do a radiology check. The tube is very well established at that point. The tract is very well established. So the stomach is located on the left-hand side of the body. I don't have a dummy with me to show you, but I think you can imagine. You're going to need a stethoscope, okay? You're going to want to hook up the plunger to the tube itself on the body. And then you're going to want to push in a small amount of air, okay? And when I say small amount, I just mean about 10 cc's, okay? And when you push that air in, you should hear a gurgling sound in the stomach. Now, this is not the best way to check for placement. It's really not recommended anymore, but it is still in our Ebenezer policy, so we should still do it. Now, besides checking for air, we also want to take the time then to pull some fluid back. You want to see some gastric contents. If you see gastric contents, we're going to be pretty certain we're in the stomach. So once you, push the air in, you can then pull some fluid back. If you hear the gurgling sound and if you get some fluid back, it's pretty safe to say we are in the stomach and it's safe to proceed. You should do this every time you give meds and every time you start a tube feeding. Now, with the feeding itself, we use the Kangaroo pump. This is a pretty easy to operate pump. very basic. So we can, it's always good to have it plugged in and charged. Once we get to no battery juice, it's gonna beep at you and it's gonna be pretty mad. So turn it on. You're gonna see that kangaroo running around, and I'm just gonna take out the tubing here so we can start fresh. Most people that we are giving a tube feeding to already have the settings in there. What we should do is compare the settings to what we see in the MAR. In this case, let's just start over fresh. So let's clear the settings and let's start over. I always like to start with the feed and then go to the flush. The bags that we use are very nice because they have it's stuck. It's a dual-sided tube, so one side will have the bag and the other side will have the tube feeding. And they just hook together. So we take the end of this tube, remove the cap, and we spike it into the bag. Once we do that, we can hook the feeding up. So this end clicks in here. The tubing pops in here, and then you can close the door. At this point, you can fill the water bag up as far as you want. I'd fill it up to 800-900. You're gonna need the water. And at this point, we can prime the pump. When we prime the pump, I don't usually use auto prime. I like to have full control of it. So we can prime the flush, just hold it down the whole time, and then the water is gonna work its way down the tube all the way to the patient. And you can stop when it gets there. To do that, just let go. And then the same thing with the feed. Just take and hold this down, and the feed is now going to work its way down that exact same tube all the way to the resident. Once it's primed, we can hit done. There's two categories that we want to work through. First is the amount of food that we want to put into the body. We have the feed rate and the volume to be infused. So you do have to do some basic math sometimes. If resident A is supposed to get 1,000 milliliters of tube feeding, and we want to give that at 100 milliliters an hour, well, that's going to end up being, 10 hours. So, feed rate. We're giving 100 mils an hour. This button controls the 1, this one controls the 0, and the next 0. So you can just push it. If you happen to go too far, let's say we needed 140 and you hit 150, just keep pushing it. We'll get back to 1 eventually. Oh, look at that, I went over. Are you kidding me? There, back to 100. So we want to give 100 mils an hour, and then VTBD is volume to be infused. Well, we are just going to go ahead and give a total of 1,000 mils. So we'll give 100 mils an hour, total of 1,000 milliliters for the feeding. That'll run for 10 hours. Now, we can't forget the flush. So we'll hit done. Okay, so now adjust the flush. I'm seeing flush volumes at about 150. We'll enter that in. Flush interval, we can say we're going to do that every 2 hours. Hit enter. Okay, we literally have the entire thing ready to go. 100 mils an hour of food. We can flush 150 mils every 2 hours. We're giving a total of 1,000 mils. We will be done in about 10 hours. At this point, we can just run it. If it's going to give you any problems, it will let you know. If it beeps, it's probably because the tubing is kinked somewhere down the line. Just follow the tubing all the way down and check that out. It could even be off at the G-tube itself. It could be kinked there. A lot of times these tube feedings will clog, and they'll clog because of the medications that we put in. So we want to make sure that we are giving a sufficient amount of water if we need to. Don't be afraid to give 30 to 60 if you have to, just to push it through. And then if you're starting to see medications line up on the side of the tube, the G-tube itself, you can go ahead and physically push some through if you have to by putting the plunger on and pushing through. But that shouldn't be our general practice. At any point in time, you can hold the feeding and then unscrew it from the resident and then give the meds. Keep in mind that two of the most common meds that we give around here that need to be given on an empty stomach are levothyroxine and carbidopa-levodopa. So the general rule is to give medications 1 hour before a feeding or 2 hours after. So keep that in mind. Aspiration is a big problem, and aspiration leads to high levels of pneumonia, more infections for us, more antibiotic use, and then, well, it just kind of spirals out of control there. It's important to keep the head of the bed at least 30 degrees. You know, if a resident wants to be at 30, that's fine, but honestly, we should have them sitting up as much as possible. Imagine yourself laying down flat in bed, eating a meal. You're probably going to burp, you're probably going to have some acid reflux, you might even throw up. That's why it is important to also check the resident's dentition every once in a while, make sure their teeth aren't turning yellow or rotting. Sometimes the tubes might get displaced. If we see a bunch of feeding just kind of coming out, spewing out, along with a bunch of drainage, we do want to go ahead, replace the tube, and then get an x-ray. Fluid imbalances can happen as well. Jill is very good at looking at weights. She is very good at knowing how much tube feeding to give per kilogram of body weight, and also fluid flushes. Our job is to check for fluid overload and then respond to any labs that may be off. For our nursing care, like I said earlier, check for placement, listen for bowel sounds every once in a while, palpate the stomach for any rigidity, any distension, any tenderness, and if there is any, we may need to do something different. If a resident is consistently throwing up from their medication, not their med, their tube feeding, there's a chance that their body is rejecting it. If that is the case, we may need to look at goals of care. They may not be able to keep going with the tube feeding as they have in the past. If anybody needs to go through this in person, let me know. I am more than happy to help. But that is the basics of it right now. Thank you for listening.